Yeah, good afternoon, everyone. I want to welcome you to this 31st session that we are holding today. Thank you for those who have successfully logged in. By names, I'm called Simon Oriokot, Assistant Nursing Officer at Yumbe Regional Referral Hospital. I'm here to moderate and take you through this session. We are here blessed with panelists who are experts, who are going also to introduce themselves to you so that you know them. Otherwise, I believe it is going to be a wonderful session and we'll like it. Thank you. Let me start from the far left. Please kindly introduce yourself.
Thank you very much, Mr. Oriokot. I am Daniel Olinga, doctor, doing emergency medicine in my final year, and I'm enthusiastic in resuscitation, really. And I'm glad to be here for this 31st session of ECHO React, and we are glad to be reaching out to the country at wide. Thank you very much.
Yes, you're welcome, Dr. Olinga. Yes, my neighbor.
Thank you very much, Simon. My name is Betty Nakabuye. I'm an obstetrician and gynecologist at Rubaga Hospital. I'm glad to have pregnancy issues related to pregnancy and trauma tabled and really the information brought to people. I'm looking forward to sharing.
Thank you so much. You're welcome. We also have one more expert who is not yet in place, but we are hoping to receive her soon. But besides that, we also have a guest presenter who is online. So if she's still on, would like her to introduce herself. Thank you. You can kindly unmute and introduce yourself, Sister Daniela. We hope you are on.
Good afternoon, everyone. Anasanait Daniela, registered midwife, stroke a critical care nurse in Arua Regional Referral Hospital. Thank you.
You're welcome. Before we continue, we also have a special guest in the house, who is the country director of SID Global Health. Let her introduce herself. Mr. Welcome.
Thank you, Mr. Oriokot. Good afternoon, ladies and gentlemen. It's a pleasure to be here. Thank you for participating in all the 30 sessions and being here for the 31st. I'm very excited to see that we've gone this far and will not be able to do this without you. So thank you.
Yeah.
All right, so there's something that they wanted me to share, before we start the session. Once again, to thank you for participating in the ECHO program. We know that this program, has enhanced your knowledge and awareness of emergency care, as we've heard from the evaluations and the post-tests. We've received feedback, a lot of feedback from you on the need for certification and certificates. We've been able to receive this feedback positively, and for the session that the first we just completed, we shall provide you with a certificate for those who attended more than five or more sessions. The team will be sharing with you a link. Please do not share that link with anyone. It is just for you. And from that, once you finish answering the questions, there will be a certificate auto-generated from that link. The other item that I wanted to talk about is the item on teamwork. We know that the ECHO program, through the online sessions, we improve the knowledge and awareness. However, when it comes to the skill, given that, emergency care is a practical, disciplines, there is need for additional mentorship. And, a lot of work needs to be done beyond the sessions. So together with the ministry, we thought of, how can we improve the skill and also really impact the patients beyond the session. So we came up with an idea, what we call the React teams, and this is really enhancing teamwork, enhancing you able to respond to an emergency as a team, and also improving response time. We received a lot of feedback that, people have the knowledge, but when there's an emergency, we take maybe more than an hour to respond. So as a team, we shall be working together with you all to provide hands-on mentorship, training, physical training, and also supporting the teamwork aspects, and also providing some equipment that you may be lacking to respond to an emergency. So for starters, we are going to do this in 21 facilities, starting from the regional, national regional referral, and a few general hospitals. We hope that, as resources become more available, we can be able to spread out to different hospitals. I'm told that in Uganda, probably Rubaga Hospital is the only one which has such a team in place. So probably we shall have time to also visit Rubaga and see how they are doing it. So I want to encourage you, if you've been identified by your hospital director, administrator as a React team member, please, participate in the sessions, the online sessions, and when we do the hands-on, mentorship, you're available. We shall be able to support you more to respond to the emergencies that come to your facilities. So with that, I want to thank you all once again for participating. A special thanks to those attending as a team. I'm told Moroto Hospital, I don't know if they are on, maybe later they will say hello to us. They're joining us, I think, for the first time. Yes, so, and also thank you to our experts who really make these sessions very worthwhile. We do not take it for granted. We really appreciate your time. So with that, I want to wish you a nice session, and we'll be speaking more, about the teamwork and the React teams later as we come, to your facilities. Thank you so much.
Thank you so much.
I see someone is saying Moroto team is on.
Okay.
Yeah, thank you so much for joining us.
Yeah, thank you so much, Director, for the brief communication. We really appreciate so much. These sessions have helped us, and we will appreciate with the results, maybe when you have done some survey to find out what is happening. Otherwise, we are grateful. Meanwhile, we have also been joined up by the other expert who has just arrived. Kindly introduce yourself.
I'm Dr. Ravin, Nalimbazi, Paediatric Surgeon, Malawi, National Referral Hospital.
Yes, Dr. Ravin, you're welcome.
Thank you.
Yeah, this is not the first time we are talking about trauma. There was a previous session, that was last week, which was the 30th session. There was something we're talking about ATLS, that was Advanced Trauma Life Support. And kindly, we want to welcome Dr. Linga to give some brief recap of what this is all about. Thank you.
Thank you very much, Mr. Simon. So previously we had introduction to advanced trauma life support, and I'll just summarize the key aspects of advanced trauma life support. And we say that while performing advanced trauma life support, we are carrying out simultaneous events. So these events include diagnostic and therapeutic that are intended to promote or to bring about life-saving and limb-saving decisions. So in the life-saving, you want to preserve life. Limb-saving, you want to avert disability in this patient who has been involved in trauma. So we normally consider this, as we are starting the advanced trauma life support protocol, that it should be occurring within the first hour, which we call the golden hour. So in the golden hour, we are carrying out the primary survey. We are having a brief history, which is the ample history. I believe those who attended remember this. Then lastly, it's the secondary survey. Then you can then prepare your patient for disposition to the relevant bodies like critical care, ICU, or transfer them to the higher hospitals. So in primary survey, we say we are going through the airway, breathing, circulation, disability, and exposure. But our aim in all those is to identify the life-threatening event, manage it, then monitor your patient. After you've done the 5 steps, you can reassess. But remember, you want to immediately identify the life-threatening. So if I come to an injured patient and I call him by name and he responds to me, definitely the airway is patent, but his leg is bleeding out. So I skip to C and arrest the bleeding. So those are the events we are trying to carry out in primary survey. So once your patient is then stable, you can ask for a brief history, mechanism of injury, if there are any other patients who died within that event of trauma. Once your patient is stable, then after, you go through the head to toe examination, like we shall keep repeating in other special cases, pediatrics, and also trauma, like we shall see today. So the secondary survey is important, that you go through a detailed head to toe examination to identify any other events that you missed out. And that is really what we do in advanced trauma life support. Thank you very much, Mr. Simon.
Okay, thank you so much, Dr. Olinga, for the brief recap of the previous session. So I believe now we know where we are going to start from as we are dealing with these special cases. These are cases that are really serious. When you look at a child or a pregnant woman who has fallen in a victim of trauma, there are specific things, as we are going to learn from the experts, that we are going to consider. So as we are moving on, before we welcome the expert, meanwhile there are polls that are running. The pre-test, kindly respond to them and submit as we continue with the session. Otherwise, I want to welcome Dr. Betty to give an introductory part on an approach to a pregnant trauma patient. Thank you.
Thank you very much, Simon. So, pregnant women have everything else that a non-pregnant person has, other than, on top of that, they have a baby. So everything else we have learned about trauma, they are at risk of it and much more, because they also carry a brain, they carry a heart, they carry lungs, they have intestines, they have the legs. So the basic principles of management of trauma still apply. However, on top of those, there are a few things that pregnancy affects, and they either affect how we manage trauma, or pregnancy makes the effects of trauma worse.
Excellent.
I'm sharing this.
Yeah. You share this.
Are we sharing? No?
Okay, thank you so much. Maybe as we are continuing to answer the polls, let's also get 1 or 2 expectations that we have for today as you're answering the polls. Thank you. Somebody there can raise a hand so that you're picked. What expectations do you have for the day about this trauma in special groups? Thank you. I hope I'm audible enough. Any expectation that you have for the day? Otherwise, let's continue with the polls.
Hello.
Yes, we are getting you. Your network is not clear.
Is to acquire knowledge about the same topics that are going to be discussed.
Okay, thank you so much.
I am Herbert from Barara Referral Hospital.
Thank you so much, Herbert. We believe the expectation will be met. Somebody else with a different expectation? Yes, please go ahead.
Yes, my name is Mwaga Hannington. I go from Mukono. I do expect to advance my knowledge in management of trauma patients as they approach on the emergency department.
Thank you so much for the wonderful expectation. Yes, there's another hand there.
Thank you so much, Mr. Simon Oriokot, the moderator, and the whole team. My name is Paya Soronon. My expectation here is to probably get a difference or a specific approach on how to manage trauma in these special groups that mentioned children and then pregnant mothers. Thank you so much.
Thank you so much, Mr. Pius. There's another hand there. Kindly unmute.
Hello.
Yes, please. Unmute and go on, please.
Yes, this is Tim Somalia. One of our expectation is to know how different the anatomy of children is in their management in trauma.
Okay, thank you so much. I believe we are finishing up with the polls. Kindly mute those unmuted. Make sure you mute your audios. There's one more. Otherwise, thank you so much for that part. We want to continue with Dr. Betty. You're welcome.
All right, so back to trauma in pregnancy. Like I said earlier on, there are a few things that are different for pregnant women compared to the non-pregnant woman, and everything that a non-pregnant person can have, a pregnant woman can have, and more. Trauma is as common as any other thing to non-pregnant women, and almost 7% of all pregnancies worldwide get trauma in one way or another. It's in fact the leading cause of non-obstetric maternal death. In Uganda, we don't have as much data, but the risk of a woman and a man getting affected by road traffic accidents as the commonest form of trauma that arrives at the emergency is nearly the same. And almost 66% of road traffic accidents among women are in pregnant women. Motorcycles, usually the crashes are the hugest, and as you can imagine, your body is the protector in itself. The motorcycles don't have anything protecting, so the woman's abdomen is out there in case of a motorcycle being involved in a road traffic accident. On top of that, we have close to 15% of injuries and trauma presenting to the emergency being intentional. And the commonest cause is intimate partner violence, with close to a quarter of these women being pregnant women. And that's why we want your attention to trauma in pregnancy to be drawn. And still, it has been noticed that lower extremities, the legs, are second to head injuries as presentations in the accident and emergency unit. And as we know what we need the legs for when we are pregnant at the time of delivery. So that's why this topic is very important. There are a few things that change when we are pregnant that may change the way we look at a woman in the accident and emergency unit who has been traumatized. I want us to note one thing, that every time you see a trauma patient who is a woman and in the reproductive age group, always rule out pregnancy. The reason is some of the pregnancy changes mimic shock, so there might be a tendency to overtreat. Others hide shock, others make shock worse, and others increase the risk of thromboembolic phenomenon. If I'm to talk about those that mimic shock, on the left side, on our right side, you can see that baby lying on the inferior vena cava. And the inferior vena cava is complaining, "Get off me." So most times when a woman lies supine, which is usually the case when we are resuscitating, if they are pregnant and their pregnancy is more than 20 weeks, the baby at the womb and the contents of the womb are sitting on the inferior vena cava, so blood is not flowing from the legs back to the heart. And of course, if we have a reduced venous return, we have a reduced cardiac output, and definitely the blood pressure may reduce to almost 30% of what the previous blood pressure would have been. So we may get carried away by that and manage it as shock, but it is actually being masked by that. Secondly, first trimester, some may come in with ectopic pregnancies and they are also traumatized. They have a limb broken, but they had their pre-existing ectopic pregnancy that had ruptured. So yes, we have true shock from that trauma, but we may also have shock from an ectopic pregnancy. So it is something that we have to think about. Secondly, the blood pressure of any pregnant woman usually reduces in the first trimester. So those are the things that usually mimic shock. Some things hide shock in pregnancy. And the commonest thing is because our blood pressure and the total cardiac output increases up to almost half in the third trimester, usually between the 30th and the 34th week. The cardiac output and the blood volume increases. So by the time someone's blood pressure drop is peaked, they have lost close to half of their blood volume. So there is need, especially when someone presents to you in after 30 weeks and they have relatively low blood pressures, just know that they've lost a lot more than what you may see. Other things that make pregnancy noteworthy is there are some changes that make bleeding worse in pregnant women. Still, this picture of a baby lying on the inferior vena cava is reflecting what happens. We usually have a reduced venous return from the lower part of the body, and this causes a lot of venous stasis on the lower part of the body. So if you get any injury in the lower part of the body, you tend to lose more blood when you're pregnant than when you're not. Secondly, there is increased blood flow to the pelvis, and if you get any pelvic injury, then the loss is quite huge. Of course, there is also a reduction in your oxygen reserve as a result of the diaphragm being on the upper aspect of the body. It pushes up your lungs, so the amount of air you're getting is less. And yet, we have an increased oxygen demand. You know, our demand is per kilogram weight, and the baby is adding on the weight, the placenta, and everything. So even with a reduced oxygen reserve, we have an increased demand. So if we are resuscitating and there is need for oxygen, that has to be beared in mind. There is an increased risk of aspiration as you're managing your airway. We have delayed gastric emptying when we are pregnant because of the progesterone and of course the baby pressing the stomach up. So because of that, as you're managing airways of pregnant women, have that in mind. Then the abdominal anatomical changes also affect how we manage trauma in pregnant women. The uterus displaces everything, as you can imagine. It displaces the stomach up, it pulls the blood along with it up in the abdomen. The gut is up. In the first trimester, you have a small womb that is in the pelvis and is a bit protected by the bony pelvis. But as the pregnancy progresses, the uterus is exposed, the walls become thinner, and the abdominal walls too become thinner. I mean, imagine a balloon blown. The more you blow it, the higher the chances of it bursting. So if you get an insult from the outside, chances of your abdominal organs being affected are very high. Secondly, the pain perception is also affected by this displacement. So those are the few changes. This is a graphical presentation of the cardiovascular changes that I mentioned per trimester. I want to draw your attention to between the 20th and the 40th week, where our blood volume is increasing, the plasma volume is increasing, and the red cell mass is also increasing. So while all this is happening, I'm going to go back here. There is increased risk of thromboembolic there is increased risk of venous thromboembolism. So these women are at risk of making clots, but also at increased risk of getting disseminated intravascular. So on top of their existing trauma, they may bleed more. Then at the time of delivery, some may present, of course, many are moving from wherever they are. Like I said, road traffic accidents are the commonest cause of trauma that we see. So on their way to deliver, so many may present in labor, but they've got an accident. And yet at the time of delivery, all these things that have been increasing rapidly drop. So that is something that we have to bear in mind as we are managing trauma in pregnancy and during delivery and shortly after delivery. This picture is showing where the uterus is at every gestation to just emphasize the anatomical displacements. This is basically a summary of the different systems that are grossly affected. I've mentioned many of these, but maybe the neurological changes. In case of head injury, our CSF increases. That's when our CSF pressure increases when we are pregnant, and the whole brain volume is actually also increased. The pituitary gland produces many of the hormones that support what the placenta is producing, so it's a very active cranium when you're pregnant. On top of that, psychological effects associated with pregnancy and trauma when you're pregnant. Remember that this woman is both thinking about the baby, herself, and the whole situation that has happened. Endocrine changes basically cause everything else that we've talked about. I may not dwell on them. I'm going to invite the emergency physician to take us through how what I've mentioned is supposed to be incorporated into the actual care. Thank you very much.
Yeah, maybe as the physician comes in, let's also take advantage of this time. If you have any questions regarding the presentation, kindly put into the chat. Let's use the chat for questions. Those questions will be responded to. Thank you. You're welcome.
All right. Thank you very much, Simon. And thank you very much, Dr. Betty, for introducing to the fact that the pregnant mother is slightly different in terms of physiology to the normal female that we shall meet every day who is not pregnant. Approach in the emergency setting to both the pregnant mother and the normal female is the same. But it was very important for you to appreciate the fact that there are some changes that come in when the mother starts to hold fetus in her system. So key to remember is the mother is the life support of the fetus. Dead mom equals to dead fetus. But if we strive hard to resuscitate the mother, then we shall also have chances of having a viable fetus. So those are the emphases I wanted to remind us about. And trauma generally, like Dr. Betty had hinted, can come from various angles, but we have two broad arms for which it can be blunt or penetrating. So various mechanisms can predispose you to either a blunt trauma or penetrating trauma, like we shall see. So as you approach this patient, they have been presented to you in the emergency department. There are some key questions from history that you want to obtain as soon as you can. So remember the ample history, which is really history of allergies to drugs or to food. So this guides you on what other drugs you're going to give this mother during resuscitation. Because you might bring in a drug, say for instance, penicillin, and in her history, she reacted previously to that. So on top of the trauma that you're having, you're creating an anaphylactic reaction. So it's key to identify that. Past medical history. So you also want to look out for any comorbidities that the mother has in this state for which she has presented to you, history of diabetes, any drug history, so they might be swallowing medications that are trying to actually lower their blood pressure, like mothers who have preeclampsia. And this can also affect your identification of status of shock, hence affecting your resuscitation. Dr. Betty had talked about the risk of aspiration due to delayed gastric emptying. So also identifying the last meal of these mothers is a key component, because as you're managing them, they can actually vomit and aspirate. And then when we come to E, those are the events. These are some of the things you want to back up in the history that you're trying to manage in this patient. So mechanism of injury, was it a fall when she was walking, when she was on a motorcycle and she fell? Was it a road traffic accident or motor vehicle crash? Was it a stab? If it was a motor vehicle crash and she was driving, was she on a seat belt? And those are the images we are trying to show you, that there is one that is very poor with a seat belt over the uterus itself, and it can give us some of the complications like abruptio of placenta, where the placenta detaches from the wall of the uterus, from the myometrium, and you have bleeding occurring. Was there any intimate partner violence? So these patients who come in having fought with their husbands will actually have non-specific injuries that will occur from head to toe. So asking for that as well is important. And this also, in discharging this patient, comes in handy, because you want to give the mother the eventual social support. The blood group and the rhesus group is important to identify. This is key because you have some mothers who are rhesus negative. And so as you're transfusing them or during their management, you might have antigen antibody reactions that can actually result eventually into expulsion of the fetus before reaching gestational maturity. And hence they need products like anti-D given unto them. You also need to get a quick obstetrics and gynecology history, and this looks into the last menstrual period. Some of them will not be in the right state to actually tell you this. Maybe the partners come along with them and they have their antenatal records. You could pick out from that. The expected date of delivery would also guide in informing you how close the fetus is to maturity. And then if there were any previous complications in the previous pregnancies, if she's having a second or third pregnancy. For example, a mother who had a uterine rupture previously and is involved in a motor vehicle crash could be standing a high risk again of having a uterine rupture. So having gotten some of that brief history, which actually should not be your first when you are managing this patient, because your patient is in an acute setting and is in an acute state. So start with the primary survey. So the primary survey involves the ABCDE approach, which I had already hinted on earlier, where you have to identify the complications, manage the complications, then monitor and reassess. So for airway, we want to remove anything that is obstructing the airway in this mother. So the first way to assess the airway is talking to them. So if they can talk back to you, then this airway is patent. If they're having any sounds like gargling, stridor, snoring, then potentially there is something that is occluding their airway. And hence you want to remove that offending agent to enhance oxygenation. So if there are secretions, you can actually suction them out. If there's a visible foreign body that you can see, you can actually remove it. If the mother is unconscious, like all other patients, you can support the airway. So this you can bring in an oropharyngeal airway, or commonly known as the Goodell in various settings. Then we also have the nasopharyngeal airways. From the history, understanding the mechanism of injury also guides you in suspecting other injuries that could have occurred to the mother. So while still on the airway, it is important for you to assess the risk of cervical spine, fractures or injuries. And it's at this point that you would want to actually give this mother a fitting cervical collar. So once that is stable, and all these things are done very fast. Breathing, this is where you assess if the oxygenation is adequate. So the saturation should at least be between 94 to 98. Identify anything that is compromising your oxygen saturation being in that range. For example, assess for the tracheal deviation, assess for air entry, percuss the chest, palpate for any rib fractures. It will identify if the patient has a pneumothorax or a hemothorax in the setting of trauma, so that you can decompress. If it's a tension pneumothorax with tracheal deviation and hyperresonance on one side, you can actually place your large bore needle on the second intercostal space to decompress the air in that place. And then you should correct that offense that has already come, like the tension pneumothorax. So after giving the needle decompression, you want to definitively insert the chest tube. You might not have the expertise, but this should be in your plan. Prepare for it. And like their pregnancy changes, because of the increasing size of the abdomen, the uterus getting into the abdomen, some of the organs and the diaphragm are actually pushed up. So as opposed to the normal patient who we insert the chest tube in the 5th or 6th intercostal space, we try to go higher to the 3rd intercostal space. So once you have established the complications and manage them in breathing, monitor your patient for any deterioration. We move on to C. C is a common presentation because mothers will be bleeding if they are having severe trauma. They could be having minor trauma, but they could be having vaginal bleeding. They could be having bleeding from the scalp or the limbs, depending on how the injury occurred. So always establish large bore cannulae, at least 2. So the colors that we really appreciate are gray, green cannula, or pink. So these are gauges 14, 16, 18 that are common in our setting. So we use them, establish 2 large bore cannulae, and take off samples. At least you can do a grouping and cross-matching for this mother as early as possible, and then book blood. Those samples collected can also help us obtain a complete blood count or do a rhesus test as well. If there's any obvious bleeding still in circulation, please arrest it immediately. So put a pressure over the oozing place, put a tourniquet if it is a limb that is bleeding out. Key to note is do not rush to do a vaginal exam in a pregnant mother, especially if it's minor trauma. In severe trauma, motor vehicle crash, you're suspecting pelvic fractures, potentially you will do a vaginal exam because you might actually palpate some bones in there. But for as long as the mother is bleeding, we are wary of placenta previa that could actually worsen the bleeding and the mother bleeds out. So try to go slow on examining the vagina in case of bleeding. Again, you need to monitor this patient. So blood pressure is key to get, but as you're assessing the blood pressure, the map, those machines normally can help you. The automatic machines, they can also summarize for you a map, and we want it at least higher than normal, which is 60. So you want it above 65, above 70 for this mother who is bleeding out. So while you're there, assess for signs of shock, so confusion. I've talked about hypotension, cold extremities in this mother. Urine output is also an essential factor that you need to assess in circulation. And like Dr. Betty had mentioned, because of the changes in the volume of blood during pregnancy, it is difficult for you to notice that the mother is in shock. So you have to anticipate, because by the time they are diagnosed to be in shock, they have already decompensated. So still in C, I remember there was a picture where the vena cava was trying to push the uterus. You can, if this mother is conscious enough, tell her to lie on her side, so left side, In this view, you're deviating the uterus to the left. That is where the aorta is more on, and the aorta is hardly compressible compared to the vena cava, which gives us venous return. If the mother is unconscious, the diagram below with an angle of 30 degrees, so put her on a cardboard and put some pillows or sheets under there and tilt her to her left. If the mother is in cardiac arrest and you're doing CPR at that point, it is difficult to do it when she's tilted in 30 degrees, but you can get one team member to manually, as you can see the images up there, to manually displace the uterus to the left. So this enhances return of blood to the heart during the process of resuscitating the patient. Remember that this mother is not only focused on the uterus. So the complications that might arise in the uterus are abruptio placentae, detachment of the placenta, which may be concealed or revealing. Blood might be coming through the vagina. Or they might have uterine rupture. Those occur mostly in the uterus. But the mother is a patient. Remember other solid organs in the abdomen. So perforation of the gut, laceration of the liver, rupture of the spleen. All these should be taken into consideration. And also the bladder that moves up during pregnancy becomes an intra-abdominal organ. So all those need to be taken into consideration. And if you are suspecting for intra-abdominal bleeding, there is extended focused assessment for sonography in trauma, the EFAST in a good setting. This is an ultrasound that you do on the abdomen to try and look out for any fluid collection in those potential spaces. Disability is the next level you go in. So you're assessing for the patient's level of consciousness. And the easiest to do is the AVPU. So is the patient alert and responding to you? Or do they only respond to your verbal, calling them? Do they respond to pain, or they are totally unresponsive? So that is the quick one you can do in the primary survey. Again, this mother should be assessed for their glucose levels like any other person, even in trauma. Sometimes we anchor to the injuries and forget that hypoglycemia would actually be killing your patient. So do a random blood sugar, then assess pupils for equality, so being equal bilaterally. So this could also inform you any events that are going on in the brain. It could be hypoxia or it can be bleeding in the brain. Then the last step in the primary survey is exposure. So you're trying to expose the patient to see any injuries that are obvious to you. This is the point where you also want to assess for pallor, you want to assess for temperature, do a quick abdominal exam to ascertain the fundal height, ascertain if there are any obvious fetal parts that could be suspicious for rupture, assess for tenderness over the abdomen or pain, and if it is woody hard, again, it gives you a feature of potentially a placenta abruption. Then consider a speculum exam at that point in exposure when you've exposed your patient. So that is largely the primary survey. So if you identify any complications in any system, do not move to the next system, fix it immediately, then monitor for improvement or deterioration. At that point, you're then free to move on to do your secondary survey. So for which I said the secondary survey is a head to toe exam. So in the primary, you're identifying the quick, immediate things that are going to kill your patient, stabilize them. So once they are stable, we move on to the secondary survey, head to toe. So from the head, I am palpating for any boggy masses, any lacerations, patient could be bleeding out, any obvious fractures. To the face, how is the mouth and the tongue? You're trying to go into detail of every system. As you come down to the chest, again, continuously palpate for any rib fractures. Repeat your assessment for tension pneumothorax. Do a proper abdominal and obstetric exam in detail. We already did the speculum exam. go to the lower limbs for long bone fractures up to the toes. Then the last thing you do is what the three gentlemen are trying to demonstrate for us, and that is the log roll. So the log roll helps us in assessing the posterior aspect of the patient. And here we are largely trying to identify any other injuries on the posterior part, but most importantly, examination of the spine. So we are looking out for the steps on the spine, any bogginess or swelling over the spine. And lastly, you complete the log roll with upper rectal examination to assess for the integrity of the spine, because that is where the anal reflex actually comes in. So alongside all these events, history, primary and secondary survey, you're having a team that are carrying out very many things in a short time. So you're also doing investigations for them. So I already talked about a bedside ultrasound that you can do. You can do a bedside random blood sugar. You can do a bedside ECG. So these are mothers who are tachycardic already. They could actually be getting an arrhythmia, or they're getting bradycardic. So ECG could actually help you diagnose some of those things. The other fear we have is exposing these mothers to radiation. Once you've stabilized your mother, please, benefit outweighs the risk. What would it benefit me if my mother has a rupture placenta or fracture femur and she's losing blood and I can't take her to an X-ray? The exposure of X-ray is less than 5 rads. The radiologists know this better, but it doesn't have that great impact on the fetus once you expose it at least once. But better yet, in the radiological unit, there are also lead shields that try to reduce on the amount of radiological exposure. But in all, what we are doing in trauma is to try and identify what is debilitating your patient. Like I said, life-saving and limb-saving, so that you fix those problems. So briefly, that is how we approach this patient. So get the patient done with the primary survey, get a brief history, then do secondary survey. As you're doing all that, whenever you identify something, fix it immediately. Then when the patient is stable, send them to the next center or perform further investigations that help you to conclude what you could potentially help save your patient. So at that point, the team is actually thinking where to dispose the patient. Should I take them to critical care? Should I take them to obstetrics and gynecology? Should I take them to HDU, or should I keep them a little bit longer in the emergency department for monitoring of some of the features? And the part of delivery is what I will welcome Dr. Betty to talk about, because it's also key. We need to clarify some of those issues. While you're managing the patient in trauma setting, remember there is also a fetus in the picture. So we are monitoring the mother. We say she's the life support of the fetus, but we also want to ascertain the fetal viability, because this helps us to determine when to welcome.
Thank you very much, Dr. Linga. So when do we deliver? If we have a stable mother and baby, wait, there is no need to rush. You monitor this mother for at least 4 hours in a quiet place where she's able to record her fetal movements. There should be at least 4 per hour, meaning that in the 4 hours of observation, she should have felt, what time is 4 is 16. She should have felt at least 16 movements. And if she has, then you can discharge her, she comes back for at least weekly monitoring until you're certain there is nothing, then delivery can be as usual. There are moments where you have a mother who is stable, but the baby is unstable. Here we deliver as guided by the gestation age, and we deliver if there is evidence of fetal distress, as evidenced by either an abnormality in the fetal heart rate tracing or presence of meconium if the membranes are ruptured. Or if we have evidence of a uterine rupture, certainly we have to deliver as a resuscitative measure. And we have preterm labor setting in or a fetal malpresentation, the baby has to be delivered. Or if we have this uterus mechanically limiting any other treatment that the mother may need to get better, like Dr. Linga said, mother first, mother first, mother first, baby second. Baby becomes fourth place. So if being pregnant is going to affect any other life-saving or limb-saving action, then you should consider delivery of this baby by the safest means. And most times in trauma, it's by cesarean section. However, note that a dead fetus is not an indication for cesarean section, because most times spontaneous labor occurs for many within 24 hours to a week after a death has occurred, unless your delivery is for resuscitating the mother. There are moments where we have a mother unstable and the baby unstable. We still insist that restore the mother's normal physiology first. Mother first, mother second, mother third, then baby can follow. Then you can consider emergency or urgent cesarean section if the condition is tolerable. And then you could also explore at the time of delivery by cesarean section if there are any intra-abdominal organ insults. I want to bring your attention to a perimortem cesarean section since we are talking about delivery. It's one of the cesarean sections that we do as an add-on to advanced cardiac life support. So if you're resuscitating a mother and there is no response to ATLS, consider a perimortem, in fact, not consider, do a perimortem cesarean section as one of the resuscitation measures. Like I said at the beginning, that a gravid uterus increases our oxygen demand, our cardiac demand per kilogram weight. If you take out baby placenta and everything, sometimes your resuscitation works. And this is indicated if your uterine side is exceeding beyond the umbilicus, meaning that we have a fetus who is beyond 20 weeks, has higher chances of survival, but then as well, the reduction on the load on the mother's weight is also quite significant. Less than 20 weeks, the change may not be as noticeable. There is no need to consent for delivery to do this, as just like any other resuscitation measures that we do during ATLS. This is taken as part of ATLS. So you do not need to first look for an informed consent form for the attendants to sign to do this as a resuscitatory measure. And close to 70% of them survive if the delivery decision is taken and done within 5 minutes of arrival at the emergency unit. ATLS for pregnant women is a multidisciplinary thing. So we need the pediatrician to manage this freshly delivered baby, of course, together with the rest of the teams. The picture on your right is just showing the process of doing the perimortem cesarean section. Typically the same as the usual, but a few things change. One is we usually make a classical incision that is from the navel. That black dot you see up is the umbilicus all the way down to the zymphy to the symphysis pubis. Do not worry about the neatness of that scar. For as long as you go through there, the next thing you will find, it should be a single incision. The next thing you find is a uterus. After the uterus, the B, you make your incision still in that same plane, and then the C, you deliver the baby, placenta, clamp, and continue with the resuscitation. That's it with the delivery. Thank you very much, Doctor.
So thank you very much, Dr. Betty, for the highlights on delivery and perimortem cesarean section. which she has emphasized should be done within the first 5 minutes of cardiac arrest. So you have to be very fast in getting that baby home. So in this approach to the pregnant mother, the key take homes we want you to know is that do an HCG for all females that have presented to the emergency department and they are in their reproductive age. This is to help you ascertain if the mother is actually pregnant, because it helps you change some of the approaches. Remember to go through your primary survey first. Stabilize your mother, get a brief history, so a quick ample history and some of the key events within that, then complete with a secondary survey and investigations. While restoring the blood pressures, remember fluids first, because this is the closest thing in your ED. It's not the blood bank, but replace blood with blood. Like Dr. Betty said, it's multidisciplinary. So as soon as you identify the mother is pregnant, inform obstetrics, the neonatologists, and critical care teams in a timely manner. And do not ever forget to identify a rhesus negative mother so that you give her anti-D. Those are the key points that I need you to remember from this resuscitation of mother in trauma.
Yeah, thank you so much, Dr. Linga, Dr. Betty, for the wonderful presentation. There's a lot that I've picked from here. And people who are out there, these things are very important. The nurses, the midwives, and all the other groups. In emergencies, we have to be there to work as a team. There was some issue that maybe might need some clarification. Yeah, especially on managing of this pregnant mother. In fact, you have answered part of it, because I was imagining a mother has got has got an accident. Of course, the first place they rush to is the emergency department. So the emergency should be ready to call for help, just as you have said, from the obstetric team, the midwives. So when they come, then now the assessments and all these things always need to be done timely. It is very important because most of the times midwives are left aside, yet they are important in this role for this matter. So it is an encouragement to all of us. Let's work as a team. There are a lot of things, maybe we'll bring in them later during the time for discussion. Otherwise, thank you so much. There are questions that are running out. We shall have time for answering them. But meanwhile, I feel we should switch on unless doctor has something to chip on. All right. We want to switch on to the pediatric case. As you are generating your questions, we shall answer them. Trauma in the pediatric case. We have a case presenter, that is Sister Daniela. I hope she's ready with the case. If the case is ready, please kindly and briefly go through it.
Thank you so much, Simon. Good afternoon once again. As introduced, Daniela, a registered midwife, critical care nurse at Arua Regional Referral Hospital. I'm going to take you through pediatric trauma. Thank you. Our history: AJ, an 8-year-old male brought in by the parents to accident and emergency following an RTA where he was knocked by a speeding motorcycle while riding on a bicycle. He presented with restlessness, inability to use the left lower limb with associated pain, swelling and bleeding wound on the left shin. He complained of worsening abdominal pain, no nausea or vomiting, no history of uturia or rhinorrhea, no headache or loss of consciousness. On examination, general examination, he was restless, diaphoretic, he had mild pallor, some dehydration, no jaundice and edema, no palpable lymph nodes. On local examination, overall there was a deformed left lower limb, swollen leg with a wound 2x2 with mild bleeding and tender. Per abdomen, mild abdominal distension, generalized tenderness, worst at the epigastrium and left hypochondrium. Bowel sounds were present and normal intensity. We did a tap, a 4-quadrant tap, and we tapped fresh blood. Respiratory system, his oxygen saturation at arrival was 95% on room air, and respiratory rate was 35 breaths per minute. He had normal percussion note, bronchovascular breath sounds with no abnormal sounds. Cardiovascular system, his blood pressure was 65 out of 45 millimeters per mercury. The pulse rate was 120 beats per minute, regular. Capillary refill was 2 seconds. No obvious temperature gradient. He had no neck vein distension. Then heart sounds 1 and 2 were heard, and no added sounds were heard. Central nervous system, AVPU, normal. AVPU,
Please, we are not hearing you.
sorry for that. AVPU was normal. No obvious craniopathies or signs of meningeal irritation. Normal motor and sensory examination was done. Interventions, we used the ABCDE approach. The airway was clear and cervical spine clear. Breathing was normal. Supplemental oxygen via nasal prongs, 2 liters per minute was given, which rose his SpO2 to 99%. Saturation, we established 2 IV access, sampled blood for CBC, grouping and cross-matching, later on transfused 2 units of blood. Meanwhile, while waiting for blood, we gave 20 mils per kilogram of normal saline over 15 to 20 minutes. As we are waiting for blood, IV transemic loading dose was given 15 milligrams per kilogram over 15 minutes and maintained on 5 milligrams per kilogram. After 30 minutes, his BP rose to 70 out of 50 millimeters per mercury. Pulse rate was 110 beats per minute. Disability, he was alert. PAL, RBS was 6 millimoles per liter. And exposure, there was no hidden injuries and he was covered with warm clothing. Log roll and further cervical spine was done and was clear. Adjuncts, abnormal abdominal ultrascan hemoperitoneum with a ruptured spleen grade 3, X-ray left lower limb open immuniated fracture, urinary catheter was inserted and drained 50 mils in the first hour, limb immobilization was done, IMTT was given 0.5 mils, IV paracetamol 500 milligrams start was given, and we gave him IV ceftriaxone SB 1.5 gram start. Ample history, he had no allergies, not on any medication, no significant past medical history. Last meal was 4 hours ago. Event was RTA. Our impression was intra-abdominal bleeding secondary to a ruptured spleen, comminuted open fracture of the left tibia and fibula. Follow-up was done, surgical team notified and preoperative care was instituted. Emergency XLAP was done with splenomegaly. Later on, an ORIF was done for the fracture. Thank you.
Yeah, thank you so much, Sister Daniela, for the wonderful case presentation. It has been a brief one and precise. And we want to welcome Dr. Rovin to make some comments on the presentation. Was it well managed according to you as the pediatrician?
Okay, thank you very much.
Yes.
Thank you, Daniela, for your presentation. I've been called to comment on to that presentation. Grossly, that presentation was okay. However, for children, as we all know, children are a special population. These people are not a one-size-fits-all. An 8-year-old, we could all be 8-year-olds, but we vary. We vary in our weights, we vary in our normal vitals. So when you meet such a patient, it is vital that we have what you'd call the adjuncts in this case. You need a weighing scale, you need a BP machine, you need a tape measure. So it is always hard because usually most trauma centers receive more of the adults. So we usually assume the medications for these children. Case in point, this child got like a 500 milligrams of paracetamol, but we do not know the weight. All drugs for children are titrated per kilogram body weight, even though it is fluid, even though it is blood. Even blood comes in as a drug for these children. So you can't say, let's give 200 mils. It can't fit everyone. So it would have been good to have the weight for this child so that it can help us measure, like when we say we are going to give fluids at 20 mils per kilogram, we have a weight to base on. I know in most trauma centers it's hard, but even when you have an adult weighing scale, you can do the subtraction measure, carry the child with the mother, then also take the weight of the mother and subtract, because I imagine some of these children may not be able to stand. So it might be hard for you to get their own weight. So you can do some of those measures to get the weight. And maybe to also continue, the next thing was still in the adjuncts to this primary survey, this is a child who had trauma. X-ray is important. For this child, only the X-ray of the lower limb was done, which is a common pitfall for us in the emergency. Section. We usually tend to concentrate on what is alarming. You see a bleeding leg, that is what you rush to. So once this child was being sent for an X-ray, an abdominal pelvic X-ray plus a chest X-ray have to be done to rule out any other injuries. Because once you miss them in the trauma center and this child proceeds, you might be reaching your secondary survey and then the child crashes, as we shall see, okay? So an X-ray for the chest and the abdomen would have been good. They can rule out for you holoviscous injury for the abdominal X-ray, for the chest X-ray, you could actually pick the nice pneumothorax, and probably the child could have needed a chest tube to be inserted. And then also for children, pain control is very vital. This comes in hand because it helps them. Once you control the pain, you will actually be able to examine these children. You do not control the pain, you cannot touch them. So if you give paracetamol start 500 milligrams, it is not adequate to control the pain for these children. So you need good pain control. I know most centers really fear morphine, but in the right hands and in the right prescriber, it actually helps. You say it will cause us respiratory arrest, but if you give it in a therapeutic dose, it is actually safe for the children. And then also, world over, we've moved away from surgical intervention for most trauma children, be it penetrating of blood. Rarely will you find a splenectomy being done for a child for a grade other than a grade 5, what we call a ruptured spleen, where all the hilar vessels have been disrupted. For grade 1, 2, 3, it is non-operative management. Hemoperitoneum is not an absolute indication for surgery in a child. Reason being, children, you know, as they are still growing, they need their spleen more than we do. It's part of their lymphatic system, it's part of what fights their infections. So you take out a spleen, you're condemning this child to having to get these vaccines, condemning them to recurrent infections. So we have moved away from hemoperitoneum is equal to surgery in a child to hemoperitoneum is equal to conserve, observe the child, take the vitals. Only if they are hemodynamically unstable despite adequate resuscitation will you go ahead and do the surgery. This child actually improved after just a bolus of blood, a bolus of fluids and then saline. So meaning this child really did not need the surgery. If you're in a center where you're able to monitor their vitals, their BPs, their pulse, monitor urine output, if they are stable, good pain control, there is no need to do surgery in such a child. This is a spleen that could have been saved. Of course, sometimes when you save them, they'll come up with hematoma and later abscesses, which can be drained, but the spleen is intact and can still serve the function for this particular child. So that being said, maybe we'll continue to the presentation. So world over, research has been done and trauma is the most common cause of disability in children. This research that was done in 2012 is a multinational, multi-center. It looked at both low, middle-income countries and high-income countries, and they actually realized the patterns differ. Vis-a-vis us in the low-income countries, our patterns are usually road traffic accidents, children move on motorcycles, which you will never see in the high-income countries. While in the high-income countries, when a child is involved in a road traffic accident, it's usually a heavy impact. It's sometimes hard to save them. These are children in high-income countries, they are usually trauma, bullets. They have shootouts at school, then you get this massive trauma of children with gunshot wounds, which in our center is rare. Rarely will you find a shootout in Uganda, because our children even don't have guns, our parents rarely have guns. But of course, as we move towards the middle income status, maybe also as our patterns will change from a fall from a mango tree while trying to get mangoes and falling on a stick while trying to pick grasshoppers. Those are usually our patterns. And usually world over, the most common cause of trauma in children are falls. Imagine in your houses, how many times do your children fall? But not all of them will actually need to come to the hospital. It's a few of them who come to hospital, and usually those are like from high falls from trees and all. And then of common cause of mortality in Uganda. This study was actually done by one of our own, Dr. Olive Sinje, in association with UCSF, and we found that road traffic accidents are the most common cause of mortality in our children. Reason being, our children going to school early morning, they're on motorcycles, we need to make ends meet. You cannot drive them to work, so we put them on a motorcycle, they have no helmets, their knees are not protected, they have literally nothing, you just put them out. You've put them at risk, basically in harm's way. Anything can happen as they move from school to home. It may not be the rider, it could be the person driving the car who loses control. So, because we've looked at a lot of ATLS, in the interest of time, I'm going to go specific to what makes these little ones quite interesting. So, still as you get a child in this case, I'm looking for someone from 0 to 18 years, and they have been involved in trauma. The same sequence happens. You don't skip anything. Primary survey, secondary survey, still hold for these children. But what makes them special is what I'm going to go to. So in the primary survey, still we know the ABCD, that's the airway, breathing, saturation, disability, and exposure. So you do not move to the airway, to the breathing, unless airway is clear. In the adults, you'll be able to ask them, what is your name? And they'll answer. But you realize our age group is from 0 to 18. You will not ask a 1-month-old, what is your name? And they will answer. So sometimes there are things you have to do for them. You have to actively look into their mouth and check and see if you have a foreign body. Or if this child is actually able to cry and everything, then you will know the airway is clear. For the breathing, still the same thing, can look at the chest and see if you have any respiration, look at the nerves, if they are flaring, and see if they are breathing. If the child is bleeding, you go through this first. Do not rush for the bleeding limb and forget about the airway. By the time you finish securing the bleeding limb and the airway is not taken care of, you already have a hypoxic child whom you might never be able to save. And then for the circulation, still will require our 2 cannulas, and we need to resuscitate these children. What is peculiar about them is their weight is not the same. A 1-year-old is not the same weight as an 8-year-old, as I said earlier. Please have the weights taken, because once you have your circulation down, you have no pulses, you need IV access. The next thing is going to be, you're going to need to give the fluids. But how will you give the fluids when you cannot calculate? You don't have the weight, because you need to give a bolus of crystalloid, saline, at 20 mils per kilogram body weight. So you need to get the weight. If you don't have any access to a weighing scale, there are ways of estimating. World Health Organization has made steps where you can measure the weight, the length of the child while they are lying down, and it also gives you a corresponding estimated weight. So most of those are not available, but still there are calculations you can use to estimate the weight and at least roughly give the right fluid for this child. So for these children, usually you're going to have to bolus them with IV fluids, at least 3 boluses as you monitor. Remember the adjuncts of primary survey that have been talked about. Have your pulse oximeter on, have your BP cuff on, have your temperature probe on, have your catheter inserted, have your NG tube in, unless contraindicated. If this child has neurotrauma or craniofacial injuries, you might not be able to put an NG tube, but have all those tubings in. One, they're going to help you measure if you have adequate resuscitation. Now, in this case, you're giving 3 boluses, and if there is no hemodynamic stability, meaning your pulse has not picked up, your child is still tachycardic, the blood pressures are low, there is no urine output, then you can move to give blood. Do not rush for blood. First, give your boluses, at least 3 of them, as it even gives you time to look for the blood. Then you can transfuse the child. The good thing about these children, unlike us adults where we're already fully ossified, these children's anatomy, they are cartilaginous. So they give you an option of, if you fail IV access, you can actually do intraosseous access. And intraosseous can save a life. Usually we prefer the proximal tibia. You can put an IO there, also the distal tibia you can put, or you can also put on the upper arm right here. But usually the proximal
tibia, just below the tibial tuberosity, is actually good. It can actually adequately resuscitate a child. You can pass your drugs, your blood, your fluids, and it will work well until this child's circulation picks up and the vessels open up. Still about the circulation, these children actually are able to hold up their blood pressures despite losing almost 30% of their blood volume. Usual circulating blood volume of like a neonate is around 80 to 90 mils per kilogram. While as they grow older, it drops to about 75 and 70. So by the time they're losing 30% of their blood volume and they are holding up, meaning once they come to your trauma bay and you just assume them to take the BP, you forget about the pulse, you might fail to pick out these children who are actually almost crashing. So in that case, you need to actually be on the lookout, check the pulse. Children will first of all become tachycardic because they have very good, their vessels are quite nice, they're able to vasoconstrict and maintain their blood pressure. So you might actually think the blood pressures are normal, but just having a tachycardia in a child is an indication of hypovolemia. So you must be able to resuscitate them. By the time they become bradycardic, they are actually crashing and it might be hard for you to save them. So still disability is the same thing. We check for the neurological status, the GCS. Of course, the GCS for children will vary with age because, for example, the verbal, you may not be able to ask that child what their name is and then they respond or raise up your name. But for them, they cool, they mourn, they are irritable. Those are the parameters used for their GCS, and then also the exposure. Still, secondary survey is the same thing as the other population. You still take the history, but of course, most of these age groups are young. The history is collateral unless the child is big enough to respond. And usually when they are traumatized, they may not talk even when they are able to. They are not comfortable in that environment. So it can be friendly. And most of our trauma bays are not tailored for children. They will see most adults around. They're traumatized to be in the same place, so they may not actually give you the history you want. And sometimes even the caretaker was brought them, was called probably from work that your child is involved in what? A traffic accident. So what is peculiar about them? First of all, their anatomy. If you look at a child, like a newborn child, their airway can be as short as 5 centimeters. That is really short. So if you're going to intubate such a child, you must be cognizant of that, because if you push your tube too far, you might end up intubating just the right main bronchus, and that is giving a single lung ventilation and collapsing the contralateral lung. So you have to be very careful. These children usually have a big head. If you look at that image on the side, the first child, for the adult, it will be okay to position them in that supine position. But for a child, you need to add a plane just below their back so that the head can drop down and you have a proper alignment between the face and the spine so that your airway can actually open up. So their boards for carrying them should always have that to allow alignment of the airway with the spine and it opens up, because just putting the position that is in part A can actually occlude their airway and lead you to hypoxia, and you know what follows next, acidosis. And some of these triads in children are quite hard to reverse. Oh, and then, since we had talked about these same children, their skeletal maturity, most of them have not yet fully ossified. This is a good and a bad thing at the same time. The good thing is, when it comes to IV access, you're able to actually put for them, but they have various options. IV, intraosseous, you can be able to stick a needle and actually pass fluid. But the downfall to this is, like, let me say, for example, the chest wall. It becomes very compliant, it's cartilaginous. So the child could actually fall onto their chest. You will see minor bruises on the chest, but the damage that is done to the viscera is high because the ribs spring down and up onto the chest. So this child will get a lung contusion, will get a cardiac contusion, will get a splenic injury, will get a liver injury, all because the ribs buckled down and up. And for you, what you see I've done my head-to-toe examination, there are minor bruises, and you assume you have minor injuries, which is not true for children. That is why for children, it is mandatory that you actually do your adjuncts. Don't skip the chest x-ray, do not skip the abdominal x-ray, do not skip the ultrasound scan. They will inform you of what is happening in the other viscera, which you may not see. Unlike as adults, once I have a problem in my chest, you actually see the bruise on the chest. But this children will show you something that looks like I'm normal, but while inside I'm actually bleeding and hurting and dying. And by the time you identify it, it is long gone. So all this need to be taken into consideration. And then the other thing, these children's body surface area, they have a large body surface area to volume ratio. What does that mean? As we all say that in E we have to expose these children and all. This makes them prone to hypothermia. I know as hypothermia sets in, then your coagulopathy will also go down. Remember the triad of death. Coagulopathy sets in, and then it's so hard to save these children. Acidosis sets in. So you expose, but with minimal exposure. You open, close, open, close. If you have cotton, like for the neonates, wrap it up, warm them and keep them warm. If the trauma bed is quite cold, if there are ACs, warm up the room. If there are fluids, all their fluids should be warmed up. Even the blood, not just get cold blood and transfuse. If you have warmers, let it go through the warmers. If it's not there, get it from the fridge. You still have 2 boluses to run, allow it warm down. Again, don't put it on a warmer because it will hemolyze and then you just give the child hyperkalemia. So all these things have to be put into consideration. Then, as I said, the normal vitals for us adults are more or less constant between you and I. But for a child, for children, they vary with age. A 1-year-old does not have the same normal BP as an 8-year-old. What is normal to a 1-year-old would be hypotension for an 8-year-old. So we have to be cognizant of the children's age, and that will help us know what exactly the vital signs for this particular child is. I know in our setting, sometimes it's even hard to come across a BP curve for these age groups, but they actually exist. That is why having a pulse in this child is equally as good. You can monitor a pulse with just a watch and your fingers palpate for the pulses. It can be equally good. It is not right, but it can help you wherever you are with these particular children. And then there is this phenomenon, non-accidental trauma for the children. It's a rising thing in our setting. It has been widely studied. However, we do not have the right systems to handle it. We identify it, post it on social media, and life continues. Our police people have the Child Protective Service Division in their sector, but rarely does it help our children. But I think if we bring it up, we can actually help these children. What is non-accidental trauma? This is trauma, in summary, that you say did not happen by accident, or it is called intentional trauma. And it's one of the leading causes of trauma in our particular setting. How do you know that this child did not get accidental trauma? First of all, there will be a discrepancy between history and examination. You get a child whom they tell you is 2 weeks old that fell down while they were playing with friends, but then has lower limb fractures. It is not physically possible for a child who does not move to have lower limb fractures from a fall. That will make you wonder what kind of impact or what was the mechanism of injury in this child. And if a child takes long to present from the time of injury to the presentation, in our setting, that time can be relative because sometimes it's constraining for the parents. Like a child could have fallen a week ago, but they have no money to bring the child to hospital. So that can be relative in our setting, but still there is a time beyond which a child appears after 3 months of having fallen. That has become prolonged. You suspect why wouldn't the mother seek help when they have a child who has been traumatized? Then if the mechanism of injury still is not tying up with the developmental milestones of a child, for example, why would a neonate fracture limbs? it does not make sense. This child cannot move. So the best thing they could hurt themselves, probably hurt their face, they bang their head from a fall, but rarely will they fracture it unless it has been a road traffic accident, but not just a fall. Then if you have a child who has several bruises in different phases of healing, they have cuts, and they have fractures, some are healing, some are fresh, please be suspicious of non-accidental trauma. And then I know we have constraints in our country, but the right thing is document it and then inform the Child Protective Services. I know one step at a time we shall be there for these children, and one time all of us were children before we became adults. So someone played their part to see who we are now. Maybe we can also play the same part. So maybe what else I have to tell you, for children, most of the injuries are actually preventable. It is us, the adults, to protect the children. So what can we do? There is what we call the ABCD for prevention of injuries in children. First, we need to analyze the data, do our own local surveillance. We depend a lot on the international data. So we need to start our own surveillance data for the children and understand what our patterns are and how can we prevent them. Then we build our own coalition, a partnership between the community and the hospital. There we can actually curb most of these problems that occur in children, and then we need to communicate them. We should have, be able to inform parents. It's sad that sometimes you see people are driving in cars with children without seat belts. They are standing in the car and you're busy driving them from home to school. It takes us to stop some of these things. You get an impact for you, be safe, but the baby will fly out through the glasses, and that will be it. I know it is hard to stop the border bees, but if you must, get them a helmet, get their knees protected, such that we can stop some of these things. And then we create safer environments for the children. If you're at home, try to make the environment safe for them. They get burns, keep the hot things away, keep them on higher surfaces, keep the knives away from these children. Then later we can evaluate the interventions and see if this can actually help. So in summary, we must remember that the children actually are a special group. They are not little adults, they are their own people, in their own bodies, with their special physiology, special anatomy that makes them different. Maybe next time we shall be able to look at the different organs, so they put them like, say you have an injury to the chest, to the spleen, to the liver. Those are all different for children and their management. Otherwise, thank you.
Thank you so much, Dr. Robin, for the presentation. It has been detailed, but we thank God. There's a lot that actually has been mentioned in it. A lot of questions are already here in the chat, and our time is also running. I believe we shall quicken up when we're answering some of these questions. Otherwise, there's a question here that will go to the maternal side. Is there a cutoff in gestational age where we will insert the ICD in the third ICS? Was a question asked by Tombe Olympia.
All right, in response to that question, I believe you're talking about a chest drain, chest tube. So when the uterus reaches the 20th week, that's the umbilical area. If you just palpate for the fundal height, most of the organs are then starting to push up. So like I mentioned earlier, the spleen, the liver, and the diaphragm pushed up. So is around 20. At that point, you should consider going higher than the normal place. Thank you very much.
Okay. Yeah, I hope it has been clearly answered. There's another question here. Can spinal anesthesia be given to pregnant mother when doing the open reduced fixation?
All right.
Dr. Betty.
Yes, it can be given. to a pregnant mother. And so can local anesthesia be given
Okay.
if whatever you're doing needs local anesthesia. But just remember that most times we need slightly higher doses of drugs in pregnancy than in non-pregnant women.
Okay, thank you so much. So the anesthesia can be given. There's another question.
And for as long as they maintain the volume,
The
the
volume.
cardio, for as long as they maintain the cardiovascular system stable. We need stable BPs and pulse, and of course they are maintained by fluids and blood.
Okay. Yeah, there's a concern here. I think maybe in the conclusions, maybe we'll see how to bring it in. Person is wondering whether why this is only staged in the national referrals and regional. But there's also emphasis that should be made in health center first, and also what they can do in that level. Maybe also in the presentation, they want to hear what can they do in the lower facilities, assuming they have received such a case, a pregnant mother in trauma, or maybe a child who has got an accident, because normally they happen down before they are transferred to the referral centers. I think it is important when we're concluding, we put on some hints as key points to take at home. It has been taken concern of. There is also an issue here. If there is fetal death, this is still by Tombe, what would prompt one to wait for spontaneous expulsion versus induction of labor? Would the mother not have a higher chance of DIC?
Certainly they would. So you would have to assess for the risk of DIC, but induction of labor is not contraindicated at all.
Okay. So in other words.
But one needs to be in a center. Every time you're choosing to induce a woman, you have to be in a center that can manage the complications of induction.
Okay.
And for Uganda, those are comprehensive obstetric care services are available at district hospital levels and a few health center forms.
So that is important. Make sure before induction, you should have all the necessary requirements. Could the presenter clarify about the need for consent before going with the perimotor cesarean section?
There is no need, just like you don't get consent to insert an ETT. I want you to look at it like the way you do all the other resuscitative measures. You do not get consent to put a cannula, you don't get consent to insert an ETT, you don't get consent to give analgesia or whatever you do in trauma life support. We usually don't seek consent. So the perimotum cesarean section is just part and parcel of the package of resuscitating a pregnant woman who needs life support.
Okay. I think this is very clear.
Otherwise, if you need consent, then it ceases to be. It becomes an emergency cesarean section.
In fact, where there is an emergency, there are some things that you will not need to ask when you know they are necessary. Yeah, it is very important. Somebody is dying and then and maybe is even unconscious.
I mean, who is going to do
that? Yeah, so there are some things you do them because you are an expert in doing them and you say they are necessary. So that was very important. Could the presenter clarify? Okay, that was if the mother gets a ruptured spleen from the trauma, how do you go about with it in pregnancy?
All right, thank you very much for that question. Again, it goes back to your assessment for hemodynamic stability. If you are in the lesser centers, health center 4, and you suspect that the mother has a ruptured spleen, stabilize her, keep her blood pressures to normal, at least to get to the nearest higher center. So that in that case, you have a multidisciplinary team coming in, so the surgeons, the obstetricians, and the neonatologists to ponder on the effect of saving the baby and also resuscitating the mother, for which if it is shattered, a splenectomy is indicated. And we know that these are stressors that will occur to the mother during surgery itself, which could later result into expulsion of the fetus in its case. So always stabilize your mother, get the BPs up, activate the ambulance services that are readily available, send them to a multidisciplinary center that is closest to you. The mother can be saved from that place.
That is very important. Maybe also to add on, there were a lot of issues both in the pediatric and then the pregnant mother. The issue of 2 cannulas, very critical issues, because now you are dealing with life. Make sure all the 2 cannulas are in place and they are functioning. Even from the lower facilities, by the time you are bringing, you are referring, there's already a resuscitation you are doing on the way. Yeah, that is very important. So those who are asking, what can we do in the lower facilities? There's a lot we can do to save this patient.
And Mr. Simon, I think you bring up a very good point. So many a times you get a pregnant mother, adult, with a yellow cannula.
Sure.
They traveled
Yes.
for over 1 hour or 2 and it's already blocked. Mother is already in shock. So at the earliest instance possible, let's get the large bore cannula in, even before referring the mother.
So the large bowels, of course, we are meaning at least gray or green cannula. So the in-charges, you ensure these things are in stock so that you don't begin running around to look for them. It is very important and saving. Yeah, there is a question here. Who is permitted to do the perimortem cesarean section? They're asking on behalf of those out of hospital care team.
The most experienced, call them skilled back attendant, but certainly a cesarean section, whichever is for Ugandan laws, has to be performed by either someone with a provisional practicing license or a full practicing license, so a doctor. So the most experienced of them all on the team is the one who should do a perimortem cesarean section.
Okay, so the most experienced. If you are not very experienced, please don't temper to do this. How can a pediatric BP measurement be achieved in case adult calf only is available? This is from Fidel Akio.
Okay. So you can, what I should say, ideally you should have a pediatric calf. If it is not available, we have estimations that can occur. Usually would say like that, we usually use the systolic.
Yes.
You'd say it's 90 plus 2 times the age, that's the upper limit, where the lower limit usually says 70 plus 2 times the age. But this is now an estimation, whether the diastolic could be a third of that. So if you know the age of the child, you can try and estimate what blood pressure should be normal for them at that point. However, but the smaller children, their systolics usually tend to match their gestational age, like for the neonates. That is an estimation, it is not accurate. That is why now we call in the pulse. It is going to help you titrate your things together. A pulse does not need any, won't tell me I can't take a pulse because I have no pulse oximetry. You have a watch, you have fingers, you can count.
Okay.
So that can help.
And so again, since we are reaching out to all of you, if the pediatric child is there, you have an adult BP, we can actually put it on the thigh.
Yeah.
Then we drop the systolic by about 20 millimeters of mercury, and that would be close to at least what it would be on the upper arm.
Okay. Thank you so much. Members, we are running out of time and the questions are many. Maybe allow me pick 1 or 2, then probably we go to the post-test as we make our final remarks. There's somebody who is concerned, why was the TAP performed in the initial evaluation rather than later with the first scan?
The case.
I think in the case.
The 4-quadrant tap. Usually we've moved away from this 4-quadrant tap if you have an E-FAST An e-fast is a quick, does not look for the organs, just looks for fluid in these full potential spaces. So if you have access to an e-fast, which I think the facility had access to, if it showed you fluid, it will tell you if this is clear fluid, is it blood, then you don't need the 4-quadrant tap. But I want to assume maybe at that time they didn't have access and they were trying to troubleshoot this unstable child, so they did the tap. Yes, it used to be done, just like a peritoneal lavage used to be done, but now with this technology, which might be really hard to find in some of, like, the missing child has come at a health center to, you're telling them an ultrasound scan or even a CBC cannot be found, the best they can do is a tap. So it will vary from which setting you're in. If you're in a national referral and you're doing a tap, I would be disappointed. But if it was done in a health center too, a 3-1, it is acceptable.
Okay. Thank you so much. This one is still also directed to you. This child got 2 units of blood. How do we calculate the amount of blood that should be given to a patient? I think this one.
Okay, so for the pediatric section, if you're going to give packed red blood cells, you give them at 10 mils per kilogram. That's why I said we need the weight, we need the weight, we need the weight.
You need the weight.
If you're giving whole blood, you're going to give it at 20 mils per kg.
Okay.
Okay, sometimes analytics depend, but it's a trauma child, so you just give 20 mils per kg. So you need the weight, you need the weight, you need the weight.
So members, we need the weights in our emergency departments and wherever we are managing these cases from. It's very important to have the weights there. For infants, at what height can I be worried if they fall down from you, Dr. Robin?
So an infant is someone below
Maybe somebody,
1 month.
somebody saw the baby fall but was found on the floor crying.
Yes, so an infant is someone below 1 year, okay? So a height will also depend. If, I won't say it would be worried, but also what part have they impacted as they fall? If I fall and land on my leg standing, there shouldn't be a problem. But if I fell and landed head first, that is where the problem is. The problem may not be the absolute height. Of course, there are some heights that will be exaggerated. We are falling from a 4-story building. It will not matter what part of the body they've impacted first. But if they are falling from a chair down, it might look short, but they've impacted the head first.
The surface.
Yes, and the surface on which they are falling. If they are falling onto sponge, it might just be something no, but they are falling onto the tiles, that is different. So you cannot say this particular height, I'm worried. All these factors have to be.
Yeah, Doctor, thank you so much. Members, I want to appreciate you for the questions. I'm sure these questions will still be answered. There might be another session. These topics don't end, so it is a continuous learning. So if you have your question, kindly, you will still have to ask. And also take use of the people we have, the seniors we have in our respective hospitals. You can inquire, consult. There are also groups, the emergency groups and all that. There are people who are technical in these things. So if you have some other question that might not have been addressed here, you can kindly ask the nearest person. Thank you so much. Otherwise, I want to appreciate you for that. The post-test is running. Yeah, the post-test is already running. Please kindly submit your answers, respond to them. As you respond, I want to get the last remarks, probably from the experts, and maybe the take-home message. Thank you. Yes, we can still start from Dr. Oli, since you are the one who opened up.
So thank you very much, Simon, and thank you, audience, for attending in such numbers. So again, it's important for advanced trauma life support for you to go through the stages like you can go through any other patient. Special populations like the pediatric population and the pregnant mothers have changes in the anatomy and physiology that you have to pay attention to. We have clarified on most of them, and so always remember, do your HCG test, resuscitate the mother, send to the next health facility if you're in the lower facility when the mother is stable. Thank you very much.
Yeah, Doctor, thank you so much. Dr. Betty?
I don't think my remarks are going to be any different from his. Just remember that a pregnant woman has everything that any other person has, plus a baby. So as you're managing them, do not forget that.
Thank you so much. Yes, Dr. Rovin.
Oh, yes, so for the pediatric population, let's not regard them as small adults. These are different people, different physiology, special needs. Make sure by the time you get to a child, the least you can do is have a weight. In that way, you won't get wrong with whatever you're trying to resuscitate, because everything will depend on their weight. Don't forget to take that pulse, it will save you. Do not hang on, I don't have pediatric pulse oximeter, I don't have pediatric BP cuff, I don't have that. We can do this wherever we are and save a life.
Thank you so much. Thank you so much. Members, we are coming to the end of this session. I believe the post-test is already being submitted. Otherwise, we want to appreciate this program so much for the organizers, that is SEED Global Health, together with the Ministry of Health for making it possible. It is very important to have knowledge. When you have knowledge, you are a powerful person to save life. Otherwise, appreciation to all who have succeeded in attending, and the team in Yube, please, thank you so much. I see you are in place. And may the Lord bless you. Switch on your cameras, your videos, so that a screenshot can be taken. Otherwise, thank you so much for the wonderful time. Hope we are ready.
Thank you so much, moderator. Yes, we are going to take the screenshots, all of us, for the session. But there's a session evaluation which is ongoing. It is assessing how on the session. So just click on your personal evaluation of how the session was. So it doesn't have right or wrong answers. And then also for the answers to the polls, we share the results, but for comprehensive results, we are going to share them on the WhatsApp group that we have. The link to the WhatsApp group has been shared. Please respond to the who are interested, you can join, and those who need access to the responses, you can email me if you don't want to join the WhatsApp group, but it's where we put most of the information. We are taking the screenshots. We are happy to see all of you. Anyone with any comment at this moment, you can raise your hand and you give any comment about the session. Yes, I see Sister Doreen Kapshave. You can give your comment.
Thank you very much. And thank you, our dear presenters. This has been very educative. Mine is about ATLS in regards to a pregnant mother. I don't know if I joined late or they talked about that, or there's a plan for that. I think it will be very essential. From what you've given us, I would want to know when we are resuscitating these mothers, what do we put in consideration? What to do compared to other categories of patients. Thank you very much.
Thank you, Sister Doreen. She was asking about ACLS in a pregnant mother. Okay, so part of it has been discussed and a follow-up session will be handled to talk about the nitty-gritties of ATLS in a pregnant patient. I see Pius, you can give your comment.
Thank you so much. The team in the house, there is a lot of niceness. Actually, I should say that the presentation has been good. From moderation, presentations, people are informed. This has been organized. Thank you so much. My objective, I said earlier, or the expectation has been met. Thank you so much. Thank you, Simon.
Thank you so much, Pius, for that kind response to us. We shall try to do better even in the next session. So please join us. Our next session is in 2 weeks. George, you're going to be our last person to give a comment. George. Okay, George, as you're taking time, let's go to Beatrice.
Thank you very much. Our specialist actually for the presentation. It's been a wonderful and quite elaborate presentation for this afternoon. I actually loved every bit of it, and mine is to thank you and keep this moving on. It's really educative and we are learning a lot. I'm talking from this side of Western Uganda, Chenjoju, Resource Health Center 4, but I can assure you it's really very, very educative, and we are really getting so much of this good experience, and we love to continue listening to it more and more. Thank you so much.
Thank you, George. The rest, thank you for attending. We shall see you in 2 weeks, and if you have any questions or concerns, please email them to one of the emails where the invites were sent. We shall respond to them. CPD points will be uploaded, and for nurses and the like, we are finalizing the process of getting accredited to award CPD points. Thank you so much. Enjoy your weekend. Do not drink and drive.
Thank you.